Welcome to Medical Myths, Legends, and Fairytales. I'm your host, Dr. Alan Christianson. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it. Hey, Dr. C here with you. Welcome to another episode of Medical Myths, Legends, and Fairytales. So, how high is your free T3 supposed to be? I see so many people really struggle with this, and trying to get it up, they end up creating other abnormalities that cause them side effects or risk, and they just don't know what to do about that. This is a big topic I've tried hard to make sense out of, and to help do so, I brought in a really good friend. This is Dr. Katie Rothwell. She's also a naturopathic doctor, and she's had a big focus on thyroid disease. She's a respected thyroid authority among her peers, and she's also an educator about this. She's the founder and CEO of the Thyroid Academy. This is an evolutionary platform to help practitioners and patients. She's a medical advisor. She lectures regularly to her professional colleagues and also consults across North America on all things thyroid care and thyroid management. And she really gets this issue about the idea of, where should these levels be optimal, how some levels seem to conflict. So please enjoy this time with Dr. Katie. We had a real good talk about this, and I think got a lot of clarity. All right, enjoy the talk. Hey, Dr. Alan Christianson here with you. Welcome to another episode of Medical Myths, Legends, and Fairytales. So really jazzed. Here we are. Dr. Katie as promised, and this is going to be a fun conversation. So Katie, how you doing today?
I'm great. Thanks for having me on the show, Alan. I'm just looking forward to our conversation tonight.
This is going to be really cool. So you and I have talked about this, and this is a topic, true confession time. There's some tricky things that I feel like I've been able to explain to people. And, you talk to people clinically as well, and the experience when the light bulb goes off in someone's head, and there's some things I've figured out where they're hard concepts, but I can make the light bulb go off. This one, I don't feel like I can make the light bulb go off that consistently.
Yeah, I hear that.
It does sometimes, but I don't know. I've had a lot of conversations about it where it's more so like, okay, I guess I won't ask anymore and let's move on. But the light bulb didn't go off.
Yeah, it's a tricky one for sure. It's a tricky conversation and tricky details to kind of go into enough, but not too much, and kind of get that information across for sure.
Yeah. And this is something you understand. So maybe you can talk about it better. Maybe between the two of us, we'll figure out a good way. But yeah,
I think together we can probably come to a very kind of nice, clean understanding of it tonight. Yeah, that sounds great.
As I kick this off, I want to share a question that was sent in to me. And I got the same question, almost the exact same wording by someone else within like hours of that one. And this is one I hear a lot. So I want to share that, and I'll read it, and I'll share an image of this gal's labs to make sense of it. And then we can start kind of talking about the issue. So there's the question. I'll just read this. You may not be able to give advice on blood work here, and I understand it, but I'm completely beaten up by this blood work. My doctor told me that I'm hyperthyroid based on my TSH, which was correct because I suffered a thyroid storm. She had a thyroid storm.
Wow.
And actually, I'm going to pop up her labs because that'll make sense to what I'm talking about. So I'm going to share screen real quick so everyone can see this. And here we go. That's the one. Are you seeing that graph of her labs that come up all right?
Mm-hmm. Yeah,
Okay.
That's perfect.
Let me get back to her question. So yeah, my doctor told me that I'm hyperthyroid based on my TSH, and she's talking about this April 7th. So the lower of these readings, her TSH is down at 0.02. She had a thyroid storm. That's a big deal. People die from those. So I've reduced my med from 120 NDT, natural desiccated thyroid, to 90, with my sights set on reversing further to 60, but I'm feeling completely dejected because now not only is my TSH not improved, but also my free T3 has dropped and is now even further out of range in comparison to where it was. So now we're talking about her April 7th against her May 4th. And so it appears the TSH has not moved at all. Yeah, it's exactly where it was. And her free T3 went from where it was just 3.9 down to 3.6. So she's on a lower dose, it went down, but the TSH didn't change.
Mhm.
I've bought your book and your program, and I've implemented the diet, which has helped me tremendously, but it's not reflected in my blood work, which I was desperately hoping it would. So that's the core of the question. And yeah, from her labs, we can see TSH was suppressed, and here it's just the same level of suppression, even though she's on less medicine and lowered it.
Mhm.
So, and there's a chart here in which it's got the normal ranges in what column E, and then what's being called these optimal ranges over in column J. And so she's saying how she is not seeing her T3 in what someone is hoping would be an optimal range. And that's the real frustration. So how does someone get their T3 in what's called this optimal range? How does it happen without the problems of TSH suppression? So yeah, let's dive in. What do you think so far?
Oh man, there's just so many things looking at that blood work that I feel like I have, comments on. I think the T3 specifically when we're using a combination medication or a medication that contains both T4 and T3, or maybe, they're just using T3 on its own, testing and interpreting T3 results can be really challenging. And there's really a number of different ways to do that. But it's all in the art of interpretation and timing your blood work, and then also having realistic expectations around that as well. So in my practice, I do use desiccated thyroid with some of my patients. So that combination T4 and T3. Most of the time, we're doing testing at what we call trough levels. So basically 24 hours since you have last taken the thyroid medication. So usually first thing in the morning, before food and drink or anything else, they're going to the lab and doing their blood work. And if we're doing trough level testing, we're essentially looking at the lowest T3 level of the day. Sorry, do you want to say something?
Well, go ahead. I've got an image.
Okay.
I'll pop up in a moment.
Sure. So after they take their medication, we are seeing a, window of time over, 4 to 8 hours where the levels of T3 in the blood are, peaking quite high and then coming back down until they hit baseline at about, that 24-hour mark even. So when we do that trough testing, we are picking up T3 in at the lowest time of the day. So when the patient's concerned, I love this graph. I have this one posted on the wall beside my desk at clinic, so I can show patients what this looks like. So when we are doing that trough testing or first morning testing before meds, we're picking it up at the lowest part of the day, and it's totally understandable, reasonable, and actually, we want to see the T3 probably at the low end of that range at this time. So for her to have that concern that, it's not optimal because, it's in the lower part of the range, I, as a clinician, that would not be a concern for me based on the type of medication she's on.
Just to expand on some of your points with the image.
For
Yeah. So
sure.
someone takes a dose here, and then there's
Yeah.
their trough as you're describing here. So you can see the dashed line is their baseline level before taking it. So this is now 24 hours out. They're higher than baseline. It's not left their bodies, it's still there, but it's lower than it is here. And the part that really I find fascinating about this graph is it shows these scatter plots. So the high line and the low line, like I'll go to this one, you can see it easier. So on this little box, there's a high and a low, and that means this was a lot of people's scores. And some of the scores were up here and some were down there. Now, if we rewind and go back to this is what, so 10 hours after a dose, maybe 8 or so, 6, 5. If we get back in here, we can see how much variation there was from person to person. So even if you knew how many hours someone was after a dose, you said, let's test you 4 hours after a dose. Well, they could be anywhere in there. There's just no way to make sense out of that.
Yeah, absolutely. And I mean, testing that for, let's say 4 to 6 hours after a dose, you're probably going to be picking up, that super physiological level of T3, and it's going to come back even high on blood work. It could come back, where I'm up in Canada, so slightly different maybe ranges that some people are familiar, but for us here, a free T3 lab range is usually anywhere from 3.5 to 5.5. And for people that maybe forget their medication and then do blood work after, sometimes those levels can be at 6 or 7 or 8. And, that's also not really what we're going for, right? We ideally want to keep these thyroid hormones in normal physiological levels.
Let me share one other image, and maybe this will make some sense out of it too. So here is a bunch of different thyroid labs that I averaged together and showed how they relate at varying extremes. So let's get this one to show up. Okay. Is that the hormone progression one? Did that work out right?
Yes. Yep.
Okay. So I've used this before in some different visual representations. I think this one makes more sense out of it. So the blue, these are TSH scores. And if you were to draw a vertical line through this, that would represent, one person's lab results. So their TSH was here, and here their free T3 and free T4 were there. And then same thing over on this end. Someone's TSH was quite suppressed, and their free T3 and free T4 were here. So you could see, and not all scores are exactly on this line, but they all come pretty close to it. But you can see the trend. So I think a big misconception, many have been exposed to the idea that healthy people have a low normal TSH. They tend not to have a TSH that's high normal. And that's true. There's good data around that. Many have taken that truth and then assumed that therefore healthy people should have a high normal free T3 and free T4. And the assumption is that there's a tight linear relationship between the TSH and these free hormones. And if we look at this graph, we can see that way out on the extremes, there's totally a linear relationship. When these are high, this is low. And when this is high, these are low. But if you look in between the two of those, it's not a smooth slope. There's a lot of ups and downs. And you can almost tell a little story with this. So here, this is someone who's at progressive levels of hyperthyroid. And what happens is the TSH is the earliest indicator about the body's overall status of thyroid hormones. It's about 50 times more sensitive than T3 and T4. The T3 and T4 are where they are because the body is trying to hold them steady. So the TSH is which way you're trying to go. And the T3 and T4, those you want to keep pegged no matter what. You're doing your best to keep them in somewhere reasonable. So as someone's getting more and more hypothyroid, they're trying to hold on to their hormone. They're trying to hold on to it and keep it in play. And there's times in which the body will sacrifice T4 and let it come down first in order to hold on to some T3. And so paradoxically, we can see T3 levels start to elevate as someone gets more hypothyroid because they're preferentially keeping it. And now on the opposite end, if someone's getting more and more hyperthyroid, it's really common to see their T3 levels start to drop. So to talk through what the body's attempting to do, the body knows that this is going to be harmful. And so it's working all it can do to get rid of T3 faster. So in the case of the gal who wrote in the question, she was somewhere around here at the one reading, and her T3 was low. Her dose was lowered and her TSH didn't budge, but her T3 went lower. And in this curve, it's not linear. There's not a direct linear relationship. So yeah. And I've seen many times where doctors will say things like, oh, if the TSH is low and these free hormones are low, the pituitary gland must not be sending the right CSH signal. It must not be working right. I'm like, no, it's the body's fighting it. The body's trying to keep all this in line.
Your body is working really hard trying to keep things in, that status quo that it wants to be. And it's basically kind of, adapting to the stress that you're putting it through from, taking maybe higher levels of medication that you should be. And that's maybe another conversation entirely. But, we have all of these background mechanisms and metabolic pathways to help to move those active hormones and deactivate them into T2 and T1 and to reverse T3. And we don't test those in the lab work often, the T2 anyways. So we don't really have a good way of seeing that process, but it is happening in the body. Absolutely.
One analogy that I found partially helpful is like the whole swimming duck one, where the duck's in the river, and you can see how fast the duck is moving. We don't know how hard it's paddling. So,
Mhm.
and the TSH is like how hard the duck is paddling, and then the free hormones are how the duck is moving. The duck wants to keep going upstream, and it'll work harder if it has to. There's a point at where if it's like a Niagara Falls, it's going to get swept downstream. And so if there's too little, eventually they go low, and if there's too much, eventually T3 and T4 go high.
Yes.
But as much as possible, the body will tweak the TSH around, trying to hold those there, against what the currents are.
Yeah. Yeah. I think that's a great kind of mental depiction of kind of what the body's trying to do and keep everything in balance as much as it can, for sure. Yeah. And, just last week in clinic, I was working with a patient who had that exact picture. Her TSH was actually quite elevated. I think it was at a 9 or a 10. Her T4 was 10. And then her T3 was actually like the high end of normal. And she's talking
There you
about
go.
conversion. And she's like, I have this really low conversion. And that's so weird. And I was like, well, really, it's not. Like, your body is prioritizing your free T3. And because we really need that for, all of our metabolic function and our cell growth and all of these things. So your body's doing the right thing. It's working really hard to make sure we have lots of T3 so we can function. But I mean, it can't maintain that forever. And
Yeah.
eventually we'll see that T3 come down.
Yeah. So the core issue I think that she was up against, this gal, was the assumption that she had to have a really high level of T3. That was a
Yeah.
mandatory thing.
Yeah.
And once someone makes that assumption, then a couple of things follow. If you do believe that's important and you give people enough medication to have that happen, you will see TSH suppression. There's just no way to
100%.
consistently have a high T3 without TSH suppression. So
Yeah.
then those that follow that end up having to argue about, well, it's not that bad. It's not that big of a deal because it's going to happen. So they either have to change those premises or argue that TSH suppression is harmless. And this is something that you've done some work on lately and you're familiar with. And
Yeah. Yeah, definitely. So, I mean, when we talk about TSH suppression specifically in the realm of, using combination medications or T3 medications, like you said, when we're using higher doses or trying to achieve these, optimal ranges of T4 and T3 and pushing our doses higher and higher, like you said, it's very often that our TSH is becoming suppressed. And there is a lot of chatter and, some advocacy groups that talk about, if you're on desiccated thyroid, a suppressed TSH is really common. It's normal. If you're on an optimal dose, your TSH will be suppressed. As long as your free hormones are within normal, it's safe. As long as you are like asymptomatic, as far as no heart palpitations, no anxiety, insomnia, it is safe. And I think that, both you and I know that that is not the case. And there are issues with the TSH being suppressed, even if all of those things meet the same criteria. But we do see that, long-term adverse effects of the TSH being suppressed like that. So that, includes things like fractures, so breaking bones. It includes, side effects on the cardiovascular and the heart, so arrhythmias. Lots of things that we're looking at as far as risks over time.
I
And I
had
know
a
you've seen some of those clinically as well.
I have, and it just breaks my heart. It's not necessary. I had a
Yeah.
kind of an odd imaginary conversation in my head with someone on the opposite side of that argument. And I was
Yeah.
thinking, well, so speaking as if against someone like that, so would you claim that no one could ever have harm from too much thyroid or from low TSH? And I would think most anyone would say, well, no, of course it's possible. Like, well, okay, so if it's possible, and you're saying that you saw a certain number of people and there's been no harm, exactly how many people would you have to see to say that they're not at risk, to say there really can't be any harm? And how long would you have to track them for?
Yeah.
Is it one person for 6 months? Of course not. The majority of smokers don't get lung cancer, and most of them don't. Most of them actually have no health complications whatsoever, a slight majority, but most of them actually have no issues. And everyone knows an Uncle Bob that smoked and drank and did fine. But
Yes.
that's not how risks work. That doesn't mean there's no risk. It means somebody got lucky.
Yeah. And I mean, the two studies that I do reference often, these are, I mean, one was, I believe, 160,000 patients over the course of, more than a decade. Like, we're talking a lot of patients and a long time. And, that those are the things that you have to, look at as far as the amount of people you're doing this and treating with this, type of approach, and following them long enough where you get an idea of these potential adverse effects. And I think as well, like, it's the, like you said, it's, what risks are you willing to take? And where's that line, right? Between, we know giving too much thyroid medication isn't maybe totally safe and it can cause adverse effects, and we're just going to hedge our bets and do just less than that. Like, how much less than that, where people are going to be, safe, essentially. And
the other issue, go ahead.
I was just going to say, our jobs as clinicians, first, do no harm, right? Yeah. And if we can't guarantee to our patients that this is not going to be harmful for them, then we really need to take a hard look at our approach and find some other creative ways to get our patients feeling better.
That's great. You talked about the 100,000 people for a decade. And, once there's studies like that, once there's data like that, let's say that even theoretically, one clinician could gather enough evidence to refute that. Let's say they could track 200,000 people for 2 decades. Well, so, and at some point, maybe they have data saying that the risk wasn't that valid based on how they do it. Okay. But what about before the numbers were in? How could you ethically subject all those people to something that may be risk when you don't have the evidence yet? For the first 199,000 people, how can you justify that?
Yes.
For the first 19 years.
Yeah, that's a very good point. Yeah.
And the thought too is the idea about the symptomatic benefit. And when the body is at this state to where it's not in physiologic normal, it's fighting against it. And there's a lot of ways by which we see symptoms even worsen. And you talked just a moment ago about what are some creative ways we could do better. And that's great. And I think often patients don't understand the fact that they are at some risk, and they're told otherwise, and they've come to accept otherwise, but they still are. And we've got to be advocates for everyone's immediate health, but we've got to be advocates for their long-term health as well. And something that might seem to help in the moment, but is causing harm or risk over time, is that's not really a viable option.
Yeah, absolutely. I agree with you fully on that. Yeah, it's often a conversation, especially for patients who are coming in and with those types of lab results from either, other practitioners, and we're having that conversation for the first time, saying, there is a potential of long-term risks, and this is what that might look like. And, how can we move forward? And, especially in certain populations, if I'm, working with a postmenopausal woman who has osteoporosis and, a heart arrhythmia, like, I'm definitely going to be even more so advocating for her to, change the medication, in some way, shape, or form, so that we can achieve, a higher TSH that's going to bring her out of that risk range.
And something I just realized too, as we're talking, I think part of the bias comes up is that in this world of natural medicine, we're naturopathic doctors. Most of the therapies that we're trained to use are things that have a pretty broad safety range. I mean, nothing is perfectly safe, and not every dose of vitamin C is safe for all people, but in the big scheme of things, you're not going to have that many problems from vitamin C, most over-the-counter products. And I think we can get a false sense of security almost in the things that we have at our disposal to use, especially thyroid hormones. They're not all like that.
Yeah. And just because, specifically with the desiccated, people are like, oh, well, it's natural, so it's safer. And, and I'm like, well, no, like, just because it's natural, one, that doesn't mean it's safe. And, it is a drug, and we still need to make sure that, we're using it safely. And that goes for, patients and clinicians as well, right? We need to be educating our clinicians and training them how to use these medications properly from the get-go, getting them at the source, rather than, for me, I came out of my, educational program. We were not educated on how to use these medications that we now have access to. So it was a bit of a search as far as like, who do I trust to teach me how to use this medication? Like, who do I listen to? And that's even was a challenge for me as, you know, an educated doctor. So, I mean, it's very challenging to try to figure out who's right and who to listen to, and how to get your levels in the best place possible so you can feel better, because ultimately that's what, you know, our patients want. They want to feel energetic. They want to be able to, you know, wake up and feel rested and, you know, play with their kids and be there with their spouses and go to work, and, you know, all of those things that we all want. So it's a real challenge for sure.
You know, back to, as you're saying, back to the well-being and the patient's symptoms, a
Yeah.
cycle I see a lot. So like this gal is kind of backing out of that cycle, but many that I see who are not feeling concerned about the TSH, they often go through this process to where they're on more than they need. And at some first level of a dose increase, they may see some benefit in symptoms. There may be like this non-specific stimulant effect, like, oh, wow, the lights came on, I'm energized again. And that goes on for few weeks, maybe a few months, then it kind of lapses. And the experience I remember is, well, you know, last time we stepped up the dose, I felt really good. And can we do that again? And so between the person and the doctor, it seems to make sense. They repeat, same thing happens. Oh, that was it. You know, I'm back again. And it doesn't last. And maybe it goes away a little bit quicker this time. And that'll often keep repeating itself. And then they hit a point at where they're on so much that now they have some just undeniable, persistent hyperthyroid side effects. Like their heart's racing, they're anxious, they can't sleep all of a sudden, and they're aware that this really got worse after the last increase. And at this point, they're stuck because they try to back down, and now they're feeling worse again. In a lot of ways, they're feeling a lot of these seemingly hypo symptoms come back again, but they don't feel they can stay on what they're on, and they can't go further, and they're like just boxed into a corner. Is that, you seen that same sort of a pattern? Or
Definitely, for sure. And I know some patients, when they go through that, like, oh, I go up, you know, go increase my dose and I feel good short term, and then I feel bad again. I think this is often talked as, you know, a situation where it's like, oh, if you experience that, that's an indication you need a higher dose. Like that's the messaging that I think a lot of people are hearing. And similarly, when they're decreasing their dose, I think there's often a time frame where people do feel, you know, maybe a return of symptoms for I usually say 4 to 6 weeks. And then, you know, we were talking before about those kind of background metabolic pathways that are going on that we don't even know and aren't even aware of. But I find that it takes a couple of weeks for those to kind of right themselves. And then the fog starts to lift again, and people are feeling good again. So when I'm decreasing doses, I usually lead with that expectation of like the first couple of weeks may not be awesome. You may feel, you know, some changes that you think you're going backwards, but like just hang with it. Give me the 4 to 6 week window, and then, you know, we will reassess. And I would love to hear your experience with that, because some of this is kind of just my own learning with my own patients, and I'm not sure if that's echoed in yours.
Completely agree. And sometimes people may be at a dose that's far, far away above what their body might ever need. And I'll talk them through that and explain that, and maybe even do a rather dramatic adjustment first to get them somewhere in the ballpark. Because you can't, when you've got too much, you can't get it all out at once. It can take quite a bit of time. And even if your dose is lower, you're not now at that lower dose until you've had time to get rid of the backlog. Also, it might take months and months and months, but you could safely go down by a lot and get it to where it's about what your body needs anyway, and then catch up to that. The way I think about it, the way I've explained it to people, is that in that cycle of a higher dose feels better, what's going on is it's starting out where there was probably already too much, and your body is resisting, and your body is amping up all these mechanisms that neutralize and eliminate and block out the thyroid hormones from getting into the cells. So the body's fighting them. And so when you first step the dose up, the body is blindsided, you know, and now this extra hormone is spilling through. And so it feels good because there's the blocking is not working and it's getting in, right? Yeah. But then the blocking catches up again. Like, oh, it quit working. And eventually you can't block anymore. And that's when the whole side effects show up. So then when you reverse that, then now you've got way too much, your body's fighting as hard as it can. And now you lower it. Well, now there's less hormone and your body's fighting off the hormone. So you got to wait for it to let the guard down again.
Exactly. And I think there's a happy balance between, you know, where we're giving just enough right? We're giving just enough hormone where the body is fully receptive and ready to use all of like your full dose. And there's none of this fighting against it and putting up, some fail safe. So we're not in that, over medication type of scenario.
Along those lines, I've come to really, I don't know, it raises my dander to hear about hypothyroid symptoms and hyperthyroid symptoms, because
Mm-hmm.
they're so interchangeable. And so often
Mm-hmm.
someone is tired and they're in that whole cycle, like where this gal was, where she's getting too much. Well, but I've got hypothyroid symptoms. Well, you've got symptoms, and they can
Yes,
come from either end of that. And I think about like the symptoms as the warning light in the dashboard, and they are what matters. And there's many that say, I treat symptoms, not lab tests. I care about my patients, not the lab values. And
yeah,
that's noble. And I agree the goal is to help people feel better, but the symptoms are not specific directions. They're not a GPS arrow saying turn right in quarter mile. They're
that's
saying,
right.
problem, but that's all they're telling you.
Hmm. Yeah. And when we are often using that lab work as a guide of like where we need to look further or what, we need to do to adjust it. And I agree, like obviously, those symptoms are important and we want people to be feeling better, but we need to use them in combination with our lab work to make sure that our patient is being treated safely at the end of the day.
Yeah. So conceptually, the big thoughts about response to your question, the first one is just the assumption about if you need to have your free T3 so high. And those who assume that inevitably have to either ignore the TSH or
Yeah,
look at the T3 after a dose has been given, in which case
exactly.
it's going to be just jumping all over the place.
Yeah, I mean, if you want to see your T3 high, just go to the lab at a different time of the day. That's what I tell my patients. I'm like, just cherry pick when we're doing our lab work, and then it'll be sky high.
You can go the next time, the same number of hours later, it'll be sky high different, but it'll
Yeah,
still be high.
exactly. Exactly.
So that's cool. Any other thoughts about this or experiences you've had, or?
I think we covered a lot of the important stuff around that. I mean, when we are talking about kind of creative solutions and things like that, I mean, some of the issues with the desiccated thyroid is that ratio of T4 to T3 is not what our body is making on its own. It's not what it's used to. It's not that normal physiological ratio. So I think that is part of the issue when we're using the desiccated thyroid, because the percentage of T3 that we're getting in it is much higher than our body would produce on its own. So, I think that looking at medication options and sometimes, like I said, getting creative around if we can adjust those ratios, combine it with more T4, look at, a synthetic T4 or T3 in a different type of ratio, split our dosing through the day. Like there's lots of different things that we can do if we do think that a patient does need more medication, but we're seeing a TSH suppression or something like that. So, but I think that in many, many cases, people are on too high of a dose and we need to bring it back down and work on some other things. Because I think sometimes we get laser focused on, I have more, like I still have fatigue or I'm a little bit groggy in the morning. Like, can we increase my dose? And I'm like, well, like, could be because you are, not sleeping through the night. It could be don't have enough protein in your diet or under fueling yourself in some way. Like there are a million different reasons why, those symptoms could be coming up, like you said, on our dashboard.
Yeah.
And it's not always that a dosage change needs to happen.
Yeah, and I think more and more, I think for many years, especially when I was just practicing and managing a lot of people's medications,
Mhm.
I was in the mindset that the right amount will solve so many problems, the right dose.
Yeah.
And so many big studies have come out now saying that in the vast majority of patients that have subclinical disease, especially, and we can talk about that in a moment, that the medications just don't help, that they're
Mhm.
just, we look at those who are treated and we looked at their symptomatic responses, at their risk of disease progression, at their health outcomes, and then medicated folks don't do better than those that aren't. And
Mhm.
these are people that, so subclinical disease, just to share for the audience, this is where the TSH is blatantly elevated, but they've not yet had that tanking T4 level.
Yeah.
And it's either here or even more commonly in Dr. Katie and I's world, a lot of folks therapy start even well before then. Their levels are normal, but they're just not optimal. And in the past, I thought that was a good time to consider therapy as well. But so much data shows that yes, you can change their levels, but we can't really change the symptoms. And I've been thinking more and more about, taking hormones or making hormones. And I think I was of the bias before that it would be identical at the same levels, but I don't really think that as much anymore. There was many meta-analysis on those with subclinical disease who have been treated compared to peers who were untreated. It doesn't help. And there's a large study that came out of Korea. They looked at 500,000 people who were medicated and they were euthyroid, stable thyroid levels. They were compared against 1,500,000 controls. And these groups were just maniacally accurately matched for comorbidity levels. Like it was like 29.2% hypertension in this group and 29.5%. It was incredibly spot on. Like all the big things that should have caused early death were just lined up. But the folks who were euthyroid medicated versus those who were internally euthyroid, the death rates were 30 to 40% higher just across the board after all comorbidities were balanced. Right. So more and more I'm thinking that making hormone is better than taking hormone. It's not the same thing. And there are those who are overtly hypothyroid and other things will not help them. And there's those that are athyrotic and it's life changing and necessary for them. But more and more, I even just question the idea of, was this right? Is this helpful? And then plus the data now showing about how many can successfully deprescribe, how many can successfully reverse the disease. So that's been a big thought process of mine that's been new as of late.
Yeah, I find that so interesting as far as, that risk with just even being on a thyroid medication, right? And what is, like, I want to understand that more because one, it's like one of the most common, if not the most common medication that people are on.
There's lists of the most commonly prescribed drugs each year, and levothyroxine is always in the top 3. A lot of years it's number 1, but you're right. This is the most commonly used stuff.
Yeah. And so many people are on it for, decades. And it's often something that when patients are prescribed, there is no conversation around deprescribing. It's like, here's this medication. Once you're on it, you take it for the rest of your life. And I think that in some of situations, there is the potential where we can do some of this underlying work and reverse whatever is causing their thyroid issues and potentially have them off of that medication that is maybe increasing, long-term risks of other things over time. Yeah,
and I wonder if it's even an issue of what the medication is doing, or if it's a lack of what the body is doing. If it's some distinction there, and I think too about ideally if they could not need it, but there's certainly a continuum to where the less they're on, the more they are generating internally, the more they are producing. We know that there's somewhere around 40 plus active thyroamines. There's a whole lot of odd little things that are not T3, not T2, but they seem to do something. And so the more your thyroid is the game, there's things happening that aren't, again, the meds are so much better than nothing for those that need that. They're awesome. They're huge advancements. But if the idea is you could have your own output better, that seems to be superior for symptom control and for overall risk.
Yeah. And I don't know, you probably see something very similar in your practice, but the people who are athyrotic completely, who've had, complete thyroidectomy or, have no functional thyroid tissue, these are often the people that, I see that feel the worst, like have zero thyroid output. And I think that says a lot about our natural thyroid hormone production and the benefit that has, and also that it may, have other things that we're just not aware of that are having benefit in our body in so many different ways.
I started practicing in the mid 90s, and there was the Rothwell study on growth hormone in aging males. There was the first formulation of Trias that came out. There was the Dr. Lee telling him about progesterone cream going around the country. These were like new ideas right at the same time. And it was this concept that all these issues of aging, of infirmity. Rhoda Barnes was still touring then too, so all these ideas were just brand new and hot, fresh ideas. Yeah. And the thought was that whatever was occurring in terms of ill health or aging, you could correlate it with these hormone changes. Mm-hmm. And the thought was you could reverse these issues by pushing the levels back to normalcy. And it seemed really logical. And so the idea has been in the thyroid world that there's good data saying that if someone's TSH is above what we would call an optimal range, they're more likely to have weight gain or fatigue or depression or progression to thyroid disease. And it seems so logical to think, well, therefore, if you could push that down, those things would do better. But the second part has just not panned out. And that's the trick. The human body is a complex system. Oddly enough, the galaxy is not. Massive things in space are not complex. You can make simple formulas and make very good predictions on them. But whenever we try to make formulas about what the body will do based upon premises or assumptions, it's a weather pattern. It's a global economy. It's a thing to where the feedbacks are not always linear. So we can only say X will do Y if we've observed X do Y consistently. We can't say we expect that, because we can't say that if A does B, then therefore X must do Y. No, we only know X does Y if we see X does Y.
The case. And I wish it were that straightforward. It would make our jobs a lot easier, right?
Well, we also might be unemployed though.
Yeah, that's true. Yeah, we do need to work. So I guess that's a good thing. Especially around the conversation around thyroid and weight. This is always a really challenging conversation with patients. Because they, often notice that as their thyroid hormones have maybe gone up over the years, or they've become more hypothyroid, that, weight loss is more of a challenge. And there's that, again, assumption that once we medicate them and their TSH comes back to normal, that, weight loss would occur and weight would improve. When we look at the data on weight and thyroid medication, it just is not there. It does not seem to change at all. And it's so frustrating for these patients, because, and how do you, it's frustrating for me as well sometimes, because, it's hard to understand how that can sometimes be, that logical case where, okay, this happened, your TSH ran up, you gained weight. If we take your TSH back down, you'll lose weight. And that's
think so.
You would think, but there are many studies showing us that is not the case. So yeah, it's a tricky biscuit.
I started practicing at that time. It was almost just standard practice to give thyroid medications as weight loss aids, apart from having any thyroid disease. And in the coming years, they put black box warnings on all of them, which still exist, saying that doesn't work. It's not safe. It's not effective. Yeah, I've told people that it's not fair. There's an asymmetry. Yes, your thyroid can get slow. That can totally cause weight gain. That doesn't mean that when that reverses, the weight just disappears. It does mean that if that doesn't reverse, the weight probably won't go anywhere, but if it does reverse, that doesn't mean it's going to be easy. It means it's more possible now.
Yeah, exactly. Yeah.
Well, that was cool. I think we got that one pretty good, unless there was anything still top of mind for you.
Yeah, no, I think that's awesome. And we covered so many great things and conversation, and hopefully we changed a few minds tonight.
Thank you so much. I want to have an excuse to connect, and really appreciate your input.
Oh, my pleasure. Always happy to join and have a good conversation with you. It's great.
All right, everyone. Thanks for being with us today. And we'll talk to you again real soon. Dr. Alan Christianson here, another episode of Medical Myths, Legends, and Fairy Tales. Take care of yourself. Bye-bye. Hey, Dr. Christianson here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christianson on Facebook or Instagram, write your question, and use the hashtag Medical Myths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much, and I'll be back with you real soon. Bye-bye.